I'm the Director of Programs for the Association of Private Health Facilities in Tanzania. I'm accompanied by Dr. Judith Njau, who will get time to introduce herself at the right moment. Dr. Berezi Makaranga will be joining us. I think she's caught up in a jam. We want to start a discussion on efforts towards implementation of the desired quality of care strategy in Tanzania and share with you the little experiences that we have had at AFTA. So my presentation will give you an introduction of what AFTA is and how we look at quality improvement and quality of care in general, the progresses that we have made and the lessons that we have learned. And then we will open up a room for discussion because quality of healthcare is an important topic and I think something that is of great concern to each one of us. Yeah, many people do not know what AFTA is. So AFTA is an association of private health facilities. Health facilities in Tanzania could be categorized into three main classes: the public health facilities, the private self-sustaining health facilities, and the faith-based health facilities. So AFTA is an umbrella organization for the self-sustaining health facilities. Our membership is more than 1,000 private health facilities. These include hospitals, dispensaries, clinics, pharmacies, laboratories, and accredited drug dispensing outlets. The membership of ADOs is coming in terms of district associations. As you know, we have over 18,000 ADOs, so if you allow them to come singly, then you'll have so many members, but with little impact. So our membership in terms of ADOs is recognized from district associations. AFTA also serves as a public forum for private health sector. So it creates a stage where private health facilities can put their heads together and talk to the government, push on the agenda and things that are concerning them. So AFTA is an umbrella organization for private health facilities representing self-sustaining private health facilities. We are participating in policy formulation and implementation as a partner to the government. So you'll see AFTA in almost all important health sector meetings and fora. AFTA also sits in various boards, including the National Health Insurance Fund Board, the FAB Board, and most public health institutions boards. Though we are a representative organization for private health facilities, we are also partnering with development partners to implement different development projects and programs. And therefore, AFTA has collaboration and relationships with the different development partners. We are also participating in delivery of public health goods, supporting the government in that area. And so AFTA is a great partner of government in terms of delivery of public health services. We are going to see in this discussion that one of the things that are really challenging the private health facilities is access to financing. And AFTA has taken it as its mandate to contribute towards improving access to affordable financing to private health facilities. So generally, we are complementing government's efforts towards achievement of national priorities in health sector. So in the discussion that we are starting, we have chosen to use the following definition for healthcare quality. We are going to define it as a degree to which healthcare services for individuals and populations increase the likelihood of desired health outcomes. And that must be consistent with the current professional knowledge. So a big question that will lead our discussion today is, how far have we gone as a country in increasing the likelihood of the desired health outcomes that we have set for ourselves since the start of health sector strategic plan 5. And again, because we are also going to talk about quality improvement, we will define it as a framework that is used to systematically improve care by standardizing healthcare processes. And this will look at both known and clinical processes. If you look at the topic, the theme of this year's summit, it is quality of healthcare in Tanzania, the current status and areas of improvement towards achieving Health Sector Strategic Plan 5. And I think it's now important to take you on board to understand what does Health Sector Strategic Plan 5 say about quality of healthcare. If you read this important document, which is actually a guiding document for the sector, it contains the following. One, that the sector would focus on improving quality of care through system-wide improvements. So we'll be questioning ourselves, how far have we gone in the past 16 months in ensuring that we are improving quality of care through system-wide improvements? The strategy also says that stakeholders will need to collaborate. But when they're collaborating, they need to really address the root causes of poor quality at health system level. Most importantly, looking at least 4 things. 1, human resources. 2, equipment. 3, supplies. And 4 is infrastructure. So when we'll be discussing, we'll ask this question. For the 16 months that we have been implementing Strategic Plan 5, what have we done about human resources for health in this country? Are equipment that are required to ensure proper delivery of health services adequate? Are they there? Do we have supplies, medical supplies? Are there challenges around that area? And what are we actually doing? How is the infrastructure? Is it supportive? Is it leading to improvement of quality of health services? The other thing that the strategy is saying is that Ministry of Health would need to facilitate an agreement on the joint quality improvement approach. There are different approaches that are being used in this country right now. I'll be sharing with you what AFTA is doing, but I also know there are other organizations that are following some approaches. The strategy wants us to have a common approach. So how far are we on that? The strategy also talks about having an accreditation system in place for both public and private facilities. So where are we on that? It also requires that there should be a patient's charter that would tell the patients what they should expect from health services and give them opportunity to ask questions when what is expected is not delivered. It also talks about carrying frequent patient satisfaction surveys, and that the system of carrying survey to ensure that clients are given the right services should be institutionalized. So where are we on this? And then it also talks about community and social accountability mechanisms to be integrated in the health sector. Most importantly, it also considers our fellows who are physical challenges. So these are the issues that the strategic plan is talking about in relation to quality of health services. So the discussion that we are starting today is looking at how far are we on this. But now, what has after done, we'll discuss that in a moment. Everyone amongst us needs to think about what his organization or her organization has done in delivering the expectations of Health Sector Strategic Plan 5. How far are we? That's the question. Now, after has taken quality of healthcare services as one important pillar, and it has been pursuing this for so many years. It wants the private health facilities to constantly improve their quality of services. And therefore, we have been participants in the big results now. You understand that, which we all participated, and it did a lot of things to push the agenda of quality improvement in this country. Back in 2011, after collaborated with Pharmaxis to start implementing safe care standards in this country, and therefore our members were subjected to these standards, and we saw quite some improvement in terms of delivery of services. Again, subsequent to that, we realized that some of our members who are actually primary health facilities were not actually participating comfortably in the standards that we were using. So we created a commensurate tool for them, which we call AFIA STEPS, Quality Improvement System. This is basically assisting the primary level health facilities to improve their quality of services with time. So it follows the basic principles of quality improvement, where they're being assessed, they're given quality improvement plan, all the required structures are put in place, and then they work on the programs that they identified gaps in their services. But going further, after realized that for quality improvement to actually happen in the private health facilities, they need financial support. Because when you produce quality improvement plan, it tells the facility, do this. For example, improve your equipment or train your staff or buy a certain equipment or improve the structure. Maybe some areas need to be improved. But health facilities, private health facilities, as opposed to the government ones, need their own capital to ensure that they implement the quality improvement plans. And this has been a challenge It's a challenge that other public facilities do not face. But when it comes to private health facilities, financing is an issue. So after realized that private health facilities needed to be supported, and we formulated a window, a special purpose vehicle, specifically for provision of affordable loans to private health facilities. We call it Afya Microfinance Limited. And we have seen over the years that as facilities access funding, they use these resources to improve quality of services in their areas. And I want to suggest to this meeting that this is an important area that needs to be looked at. Financing for the private health facilities, and in that matter, for the public health facilities also, is an important element to be considered if we have to realize improvement in quality of services in this country. So the other important element in quality improvement is the qualifications, the credentials, the competency of healthcare workers that you have. After I realize this, and as we speak, we are putting up a center to address realistic and practical gaps that are impacting healthcare workers and that are subsequently impacting quality of services in the country. And I think if more efforts are put towards capacity building of healthcare workers, then ultimately this will result into quality improvement of, in delivery of services. But the other thing that we have realized to be challenging private health facilities is the supply of health commodities. Therefore, we know a lot is happening. MSD is doing a lot, but we think there should be alternatives that would give facilities access to quality health commodities. And not only access, but timely access at affordable prices. So after is again working towards setting up a medical supply chain to contribute to improvement of quality of health services by ensuring that the commodities that are required are there. Now, these are broader issues that AFTA is working on. And we think that if we work jointly in improving quality of health services, then a lot can be achieved in this country. Recently, AFTA has been registered as a licensee of self-care standards in this country. And this is a big milestone. Today we are supporting several health facilities, including the national and regional referral hospitals, in pursuing accreditation. And this is an international accreditation that we are talking about. We are happy about it, and we are seeing a lot of improvements. In our past experience, where we registered most of our facilities under SafeCare, we saw tremendous changes. Today, we have we are proud of some facilities that stuck on the standards, and if you go there, you'll be happy. One of them is called the TMJ Polyclinic. You can visit it in Temeke, and you'll be surprised by the quality of services that you'll see there. A demonstration that if efforts are put in a manner that is impactful, then results can be realized. So, generally we are saying that we have therefore managed to institutionalize quality standards in our facilities 300 private health facilities that have been using AFIA steps, and over 500 private health facilities that have been using safe care standards since 2011. We are expecting that 2 or 3 years down the line, we'll have several big hospitals being internationally accredited through the efforts that we are making now. Yeah, so we are also continuing to provide training, sometimes through continued professional development. After it's now a registered CPD provider in this country, and we are seeing a lot of changes in this line, where we are providing trainings and building capacity of healthcare workers, having done assessment of what is required to make changes in the way they deliver their services. We are also continuing to do supportive supervision with the government, and this is another development that came over the years, where we work jointly with the government to carry out supportive supervision for both public and private health facilities. And we think if this continues, then it will not only create good relationship, but it will enable consistency in terms of health service delivery in this country. Yeah, so what are the lessons learned generally? What we have learned through the efforts that we have done in quality improvement includes the fact that every facility, regardless of whether it is public, private, or faith-based, needs to have its service delivery standards or quality improved. And I can tell you that COVID-19 gave us a great lesson. If Ebola, for example, happens here, it does not matter whether a patient goes to public or private hospital or dispensary. What is important is that when this patient goes to a hospital or a dispensary, whether it is public or private, he gets the required attention. He gets the services that are required. And that is not good only for the patient, for that patient. It's good for all of us, especially when it comes to pandemics and epidemics. I don't know whether you hear me. So this is why we are saying, when it comes to quality improvement, quality of health services, the demarcation between private and health facilities should not be there. And government efforts should permeate both sides, because we need quality of services for this country. And this has implication to the achievement of universal health coverage as well. As I said, unreliable access to financing, especially for private health facilities, is a big challenge. Today, we are encountering a problem, especially when we are enrolling our facilities to safe care standards, because most of them cannot pay the small fee that we are charging. Some are claiming that they do not receive their payments from NHIF timely, which is a big problem. Some are saying we don't have enough earnings to participate. And therefore we think, and AFTA is working very hard to ensure that there is another support that is given to, that is given to health facilities in accessing finance. Another lesson that we have learned, having worked with accredited drug dispensing outlets, we think that when this country is considering quality of care, it should not forget to include the ADOs. And the reason is we have more than 18,000 ADOs all over the country. And in some areas, ADOs are the only service delivery outlets. In fact, research shows that in hard-to-reach areas, ADOs are the only places where people go for health services. And therefore, if we do something about it, we will be doing a lot of justice to people who are downtrodden, those who are lower there. So anything that is done to improve quality of services in this country must include ADOs. Experience with the facilities that we have worked with through safe care standards and through AFIA steps is showing that when facilities are following the standards, they become viable. So it makes a business sense, especially for private health facilities, to be involved in quality improvement because they will become sustainable, they will become efficient, they will do a lot of things in the manner that is required. And through the process, they will learn a lot, including how business should actually be done. So this is another important thing that we think should be considered. We have also learned, and I think this is applicable in many areas, that even with quality improvement, we should not reinvent the wheel. We should always use the structures that are already set. We have been involving regional and council health management teams in doing the assessments. We involve them as part of the process in the approaches that we are using. And this has worked quite well. One, because it retains institutional memory, it reduces expenses, it is easier to follow, because the same people will be doing other things for the same facilities. Yeah, but another thing that we have learned is that if this country is to realize a possibility of being a place where people would be coming to seek health services, I'm talking about medical tourism, then quality of health services is a must. And this should be item of the agenda in most of the health sector discussions, right? So we are looking forward in the few coming years to see big hospitals like Jakaya Cardiac Institute, Aga Khan is already there, like Moi, becoming a center, an international center, attracting people from different places. I know they are coming now, but the number that is coming is not what it's supposed to be because there is no accreditation. Most expatriates, for example, when they come to this country, they want to have information that a certain hospital, a certain health facility has been accredited. A certain health facility has been accredited by a reputable international organization. And that is important. So as a country, we should pursue that. So what is the way forward? We think, I just want to summarize what I've said so that we can have enough time to discuss. Capital and access to affordable financing is important if we are to realize improvement of quality of health services in this country. It is obvious that in the past 16 months, since we started implementing Health Sector Strategic Plan 5, very little has been achieved in terms of quality of health services in this country. And I think we need now to re-strategize to ensure that we do enough, because June 2026 will be here with us, but no significant improvement would have been done. I'm also emphasizing that though private health facilities in this country account only for less than 30% of facilities, but when it comes to services, they account for a larger chunk. In Dar es Salaam, for example, as opposed to other areas, 80% of health facilities here are private health facilities. And therefore, whether it's about donors, whether it's about the government, whether it's about any other stakeholders, they should always think that quality health services must always consider both public, private, and in this case I mean including FBOs. Pandemics and epidemics will always remind us that quality of health services is key. Projections are showing we are going to see we're going to see a lot more of epidemics in the coming years. So this country needs to do a lot in terms of quality improvement to be prepared for the epidemics and pandemics. I'm almost done, and I think this will provide a good time for discussion. I was just putting the ball rolling for all of us to put our heads together on this important topic, quality of health services. And therefore, the floor is open. If you have any issue, any comments, any inputs, any questions, it's now. Hey, hata mnipigie makofi. Karibuni. Yes. If you mention your name, that will be a great courtesy to us.
Good morning, and thank you for the presentation. And we know private facility. My name is Dr. Faida. I'm working with MDH. Yeah, coming back to the private facilities, they contribute significantly to the services that people do get. So what is after doing, or what is the role of after in ensuring that the private facilities have a number of staff and who are qualified to provide the services? Do you do any analysis, or do you make them account? How do you make accountable those private owners of those facilities to ensure that they have the qualified providers? Thank you.
Thank you for that question. I don't know whether you need to, should I respond to that? And the question is not only directed to me. I think we have so many people who can respond to that. Okay, additional question before we respond.
Thank you very much, Mr. Dr. Isaac, for presentation. So I'm Theodora Mbunda, working with MDH. With regards to universal health coverage, with a move now to national health insurance in Tanzania, so how does your organization is positioning itself to support even the people who are going to have access to national insurance to access quality healthcare services from the private facilities? Because I know at the moment some of the private health facilities do not accept what we call the national insurance. So how do you position yourself to support that? Thank you.
All right, maybe I start by responding to these two questions. I'm only giving my ideas. The first question was, what does AFTA do to ensure that private health facilities have adequate human resources for health? As an umbrella organization, I think we are already trying to do a lot to ensure that private health facilities have the required staff. But as you know, getting the right staff would also need having money to finance them. Oh, sorry. Excuse me. It has always not been very easy. So we are talking to them, and that's why we said we need to find means and ways of ensuring that these people access adequate funding. When they have funding, and when they have accepted to be included in the quality program, because quality program must talk about human resources. And when they see the need of having a certain competency in their place, and they can access funding, having made a business proposition, because with private health facilities, it has to make a business case first. Once it makes a business case and they have a buy-in is given by getting into the quality improvement plan. Once they understand that and they have a buy-in and they have access to funding, then we can expect to have staff increasing. However, after his thinking about bringing in the unemployed doctors, we know there are so many unemployed doctors now. So we are already creating a plan to have them brought in to help reduce the number of human resources in these facilities. So these are the things that we're doing. They're difficult, but we're trying to put them together. AFTA cannot do it by itself. We're only trying to do it within our capacities. But we are calling for all stakeholders to see the importance of having adequate staff. Now, when it comes to universal health coverage and what AFTA is doing to ensure that health facilities are accepting insurance, we are doing advocacy. You see, people have to understand things for them to buy it in. And I think this being the policy of the government, with time, it will make sense. However, the challenges that our members are now facing with the National Health Insurance Fund, for example, is becoming an impediment. So we are trying to balance this by solving the problems that are happening between our members and the existing insurance, national insurance in this case, for them to be able to appreciate that things can still be achieved when we have insurance. At the end of the day, the more people accept insurance, the better, not only for the particular facilities, but for all of us. And I think with the time, we will get there. Judith, if you have anything to add, you can add anytime. Yes?
Good morning. My name is Remla Shirima from PhysioCare. I have a follow-up question to the lady who asked in regards to human resource to staff and quality of the staff. So what does APTA do to support private facilities when it comes to what I call the Great Migration? When government announces employment vacancies and then you have staff moving from private facilities to government facilities, and you find that these are staff that maybe the private facilities have invested in training, they've been there for a couple of years, and then suddenly you have a number of doctors and other healthcare workers moving from private to government facilities.
Thank you for raising that. Admittedly, that's a very big challenge that our members are facing. They train their people, they give them the right experience, but with time, when greener opportunities happen and reliable employment, especially in the public, they move. It's a big issue. But what does AFTA do? AFTA does training. So we have constant training for health facility staff. As an organization, one of the things that we do is capacity building. So we'll continue to do that to ensure that those who are working in the health facilities are adequately trained. I mentioned earlier on that we are putting up a center which will be providing customized trainings to our people. So I think when that is done, a lot will be achieved because we will be assessing the gaps that are there and providing the required trainings. And with time, well, it's not going to be 100% now, but with time there will be improvements as we go along. Yes, any further questions? There's a question there.
Okay, I'm Viola from MDH, and thank you, Dr. Isaac, for a very good presentation. Mine, I would like to know more about the accreditation that you're saying you are supporting. Because as MDH, we are also supporting the laboratory for both private and government facilities to attain accreditation. So if I'll know more, maybe we will find a way we can work together. I think we are doing almost the same thing, that to support the facility to have the quality services. Thank you.
Thank you so much. As I said, we are registered licensees for farm access in Tanzania, and I'm happy to see Dr. Risha here. Maybe he can chip in and talk about it extensively. But as you said, we will always be happy to work together. Anytime, feel free to talk to us. Dr. Risha is working for Farm Access International Tanzania office. Please, Dr. Risha, if you can add anything to respond to the question.
Thank you, Isaac, for putting me on the spotlight. We from Access are working with different stakeholders. AFTA and CCC have been our partners championing accreditation of healthcare delivery. And when we talk about accreditation, there are different flavors, I would say. Self-care, which is the approach which is AFTA is championing, aims at creating a highly reliable organizations, as the first opening speech clearly illustrated. We are looking at all areas of service delivery, from clinical services, laboratory services, and how are these linked to other service areas, even the maintenance. We all hear the story that when a generator, when the mains electricity is out and the generator has no fuel, and the critical patients die because of this. So we look on all aspects. So having said this, we are also working with other stakeholders. Currently, we are working, Farm Access is working with MDH, collaborating closely to support the ministry establish an accreditation body. So I think we know that the challenges are very big enough. No one stakeholder can address them all. And it is a new thinking. We need to have buy-in from all stakeholders. So yes, I think we're on the right path because we are working with a lot of stakeholders, including MDH.
Thank you, Dr. Risha. Thank you. Judith, do you have anything to say?
I think Dr. Risha has explained a lot concerning with the issue of accreditation. think what we are doing, we are collaborating the efforts to make sure health facilities are doing the perfect quality improvement plans in their facilities. So whether we are working with laboratories or we are working with the whole facility, the issue is patient safety is considered. That's a main issue, but in different aspects. But as we are doing for after, we make sure that we are moving to the whole facility regardless of the laboratory itself. As he said that we are going for the accreditations, that will mean we want to accredit the whole facility, not only on the laboratory part. Thank you.
Thank you so much. Our time is up, and I can see timekeeper is telling me things here through gestures. I want to thank everybody who participated in this session, and let's work together to ensure that this country's service delivery is improved. Thank you all.
Asante after. Good morning, everyone. The next session is about keynote infectious disease, and we are going to have 1 hour. Let me welcome Dr. Chilo to moderate this session. Welcome.
I just received a call this morning from Professor Pascal Rugajo, who is a Director for Curative Service at the Ministry of Health, that he's not going to make it. So he asked me to moderate this session for the keynote today, which is about infectious disease research, insights, and trends. So we have our colleagues on Mikumi. I'm not sure if they're already done with the session. They can join us. Maybe the moderator. Either way, so I would like to call the following speakers in front to join me for this session. We have Dr. David Sando. Please welcome. We have Dr. Ali Olotu from IHI in Cambridge. But then, it's unfortunately, we were supposed to have Theopista today, but we have her boss, Mr. Roland van de Ven, the chief of party EGPAF. Just to notice, our initial panel was supposed to have one female, so the gender don't scratch me after this session. So please, at least I've preempted that this is was a gender, at least gender bias. So Dr. Sando is the CEO of Management and Development for Health. Sando has 17 years of experience in developing public and private partnership with organizations such as US CDC, USAID, Global Fund, and Harvard TH School of Public Health, MOHAS, but also Sando is a research scientist and has a Doctor of Philosophy in Global Health and Population, which he graduated at the Harvard T.H. Chan School of Public Health. Can you have a clap of hands for the profile? Yes. It's an excellent profile. In addition to that, Sando is also my senior. I think he was somehow 2 or 3 years ahead of me in medical school. I'm not so sure. But ahead of medical school. Around there, yes. The second speaker is Dr. Ali. Dr. Ali is a Kemri Wellcome Trust affiliate, and he works with Ifakara Health Institute in Bagamoyo. He has an MD degree from University of Dar es Salaam and diploma in philosophy in clinical medicine from University of Oxford, UK. He is currently head of Department of Interventions and Clinical Trials, the AHI. His interest is in epidemiology of malaria and clinical trials, evaluating the public health interventions against malaria and other infectious diseases in low and middle income countries. A round of applause for Dr. Ali, please. The last one, don't have his bio, but what I know, he's the Deputy Chief of Party at EGPAF. Karib San. Maybe you should tell your bio just by saying, a little bit of profile.
Yes. Good morning, everyone, and apologies of not being female. But I was been asked by our great pediatric advisor, Dr. Theopista Masenga, to step in because the Pediatric Association of Tanzania at the moment also has a meeting on Zanzibar officiated by the president of Zanzibar, so she could not divide herself. Yes, as you said, I'm Dr. Roland van der Ven. I'm a medical doctor by profession, specialized in public health and tropical diseases. Have been working for 12 years with EGPAF here in Tanzania in the different roles as technical director and deputy chief of party. Thank you.
Thank you so much. So my job today will be asking you questions and then your response vis-a-vis the questions that have been posed to you. Our keynote today is Infectious Disease Research Insights and Trend. So I start with Dr. Ali Olotu. The question is, the country has not been immune to pandemics. So it means this is not the first time. So please give us a clear pattern of infectious disease over the past 2 decades, taking into consideration about malaria, TB, HIV, and emerging diseases such as COVID-19, measles, etc. So the second question is, defeating malaria by delivering a life-saving vaccine. We have recent results from the malaria vaccine pilot implementation in 3 African countries. Are we there yet in terms of vaccine for malaria? And what are the current challenges and promising opportunities for the future? Karib-san.
Thank you very much, Otuskilo, for first inviting me into this conference. But I think to address those questions, I want first to make it very clear that I work mostly in malaria for the last 20 years. But if you look at the infectious diseases, this would be my my general comment, and I'm sure others would be in a better position, at least for HIV and TB, to comment on this. Globally, we have made significant progress in terms of tackling these diseases, and I think that is testament to both public health efforts to roll out the interventions that have been proven to work in countries, but also research that has actually churned out some of these new interventions that have had a significant impact in the control of these diseases. Malaria in particular, because this is an area that I am mostly working on, globally we definitely have witnessed a decline of malaria over time, both in terms of the number of cases we see per 1,000 population at risk, but also in terms of the mortality of malaria over time. So there's been significant decline. If you look at the data, for instance, from early 2000, we've come down from well over 80 to, I think, around 50, 40 now, million cases per cases per 1,000 population at risk, and mortality coming down all the way from over 20s now to around, I think, 11 deaths per 100,000 of population. So I think this is a significant sort of progress. We have seen a bit of slow sort of decline for the past few years, and significantly this has been noticed in the countries, very few countries, which actually most of them are in Africa, that contribute sort of more than 20, 50% of the sort of global cases. And I think this is a cause, of course, for concern, but also cause for us to look into, what are some of the challenges these countries are facing in trying to address or to control, and ultimately eliminate malaria in these countries. So first we have to recognize, of course, the efforts that the ministries of health, for example, have worked, national malaria control programs have done to tackle malaria specifically. And with the tools that we have at the moment, we have been able to achieve this much. It's obvious that it's important to think about scaling up. It's important to think about making sure that those people who need the most, these interventions, are reached. So this is critical. But I think as we are thinking of ways to better scale up and reach those who need the most, these interventions, we also need to think of new tools. And I think the new tools may sort of push us or may take us further in the fight against malaria. So in particular, one of tool that I have sort of had a privilege to work in for the last 20 years of my career in research is malaria vaccine. And I think it has been a very challenging issue to address. It has taken almost 30, 35, 40 years up to now. So if I was to give sort of a key messages around malaria vaccines and sort of its impact or its contribution in the fight against malaria, I would say the recent achievements with RTSS, this is a vaccine that is produced by GlaxoSmithKline, has been a win in a sort of in hard-fought battle, which has taken more than 30 years to achieve. And to honor this effort by a number of scientists across the world, including Africa, I think we should fast-track the deployment of this vaccine to the people who need the most. But I would also add that the war against malaria is still on. And in order to win the war, I think we need to continue to do research and look for the next generation vaccines, so we call them, that will be more effective and sort of more long-lasting, and in addition, of course, to other tools in the fight against malaria. So I will sum up, the response to your question as we have made a significant strides as far as tackling malaria is concerned, and the recent success, something we should all celebrate, but we should make sure that we do not delay sort of deploying this current tool to the people who need the most, and those are the children, vulnerable children in some parts of Africa, including Tanzania. But then we shouldn't let our guard down and think that we are there. I think we still have a long way to go in the fight against malaria. So I would end there for now. Thanks.
Thanks so much, Dr. Ali, for a very elaborating response to the questions. If you have any question, please, you can write down, and we'll have a Q&A session after the presenters respond to my questions. I would like to go to the second speaker, Roland van de Ven. Over the past 40 years, we have seen quite some progress in HIV care and treatment. Where do you see prevention of HIV towards global targets, particularly in the area of eliminating mother-to-child transmission?
Thank you for that question. Yes, elimination of mother-to-child transmission has really been also a core mission of our organization, the Elizabeth Glaser Pediatric AIDS Foundation. And as you said, we have made good progress globally over the last, I wouldn't say 40 years, but at least over the last 10 years. If you see in sub-Saharan Africa, we have now over 12 countries that have achieved 95% of the pregnant women to be on ART. And we actually have one country, Botswana, that is the first high prevalence country that has been validated to be on the path towards elimination of vertical transmission from mother to child. However, that success is still in contrast with the number of cases we see in the world. Every day, 430 children are identified HIV positive, are newly infected, and that's still a big number globally. And even if we see that those children are not receiving the ART compared to adults, only 52% of the children that are identified are receiving ART. This is globally. Now, in Tanzania, we have also seen good progress. Tanzania has been doing very well in testing women. The country has a very stable coverage of 98, 99% of all the pregnant women that are coming to our RCH clinics are tested for HIV. But we have a challenge. We are still testing late because so far women are still coming late for antenatal care. The proportion of women that are coming in the first trimester is only 37%. That means people are coming for late booking and therefore late testing, late initiation on ART. And that poses a risk because half of the children that are infected from mother-to-child transmission is due to late initiation of ART. They may already be infected before we are able to put the woman on ART and get them virally suppressed. The other challenge is also that we still do not test all the men that are coming with their pregnant woman. In country, only 78% of the men are getting tested as part of couple counseling and testing at the RCH clinic. So despite the fact that all the women are tested, men are still lagging behind. And that also poses a risk. For example, if we identify discordant couples, we are not identifying them because we are not testing the men. And if we are testing them, PrEP services, pre-exposure prophylaxis, has just started last year in country. And we are not yet there to offer this also within the RCH clinic. I think most of the PrEP services are still focusing on key and vulnerable population, linked to index testing, but not in PrEP. And then if you look at the cascade from testing women, putting them on ART, and then identifying the children and testing the children, that's where Tanzania has a huge challenge. We are still very far from reaching, the National AIDS Control Program had a target of reaching 90% of children to be tested within 2 months, and we are far from that. We are even below 40%. So as an organization, in 2020, we worked with UNAIDS and the PMTCT unit in the ministry to look at what are the barriers that we do not seem to make progress in country with PMTCT. We have seen such a good work in the ART program and putting people on ART, getting them virally suppressed. The country has reached already above 95% viral suppression, but not among pregnant women. And one of the challenges that we have seen is maybe it's the uniqueness of how the healthcare services in country are working. We have over 9,000 health facilities in country, and we know that PEPFAR is the largest program that through many implementing partners we are supporting the HIV program, but that's only in 2,500 clinics. So a lot of clinics are not being supported, mainly dispensaries. When we did the analysis in 2020, looking at our DHAS data, we actually found that over a quarter of the newly identified positive women are found in small dispensaries that are not supported by anyone. And that's where we see a big gap between the good PEPFAR support in many of the high volume clinics versus all these small ones. Now, and they have a difference in volume. We are seeing on average, the country has every clinic has about 12 new positive women per year. That's not a lot. But you see that in the PEPFAR program, it's about 25. Those are high volume clinics, hospitals, health centers, but even high volume dispensaries. Now these small dispensaries, they may see on average 4 to 5 positive women per year. Now you can imagine that if you are a nurse in a small dispensary and once a quarter you identify a new positive pregnant woman, you do not have the means to offer services. You don't have the logistics to offer ART, to refer them for viral load testing, or even for the DBS services for the child. I think that is one of the major gaps why we are not seeing the progress. If you look at the implementing partners reporting to PEPFAR, we seem to do very well. But if you look at the PMTCT report from the ministry, we are stagnating. And I think we need to think differently on how we are going to reach all those women. Small volumes in many, many sites, they also deserve that treatment. So I think we need to learn from the successes that the PEPFAR partners have achieved. They have really integrated the PMTCT within the RCH clinic, linking it with immunization, linking it with family planning. Many of those clinics have set up peer-led support programs through mother support groups, mother to mothers. We are supporting the use of mother-child cohort registers, and we are supporting sample transportation for viral load, for early infant diagnosis. These samples are sent to the centralized labs for testing. So those successes, how can we replicate them also so that these smaller dispensaries that are over 4,000, last year we had 4,500 dispensaries not supported who identified positive women. And so I think we need to think differently on how can we reach those women as well. And one area is to better use the data at the site, at the council level, so that if a small dispensary identifies a pregnant woman, we set up a system, like a case-based surveillance system, to follow up on that woman and make sure that ARVs are accessible, that the woman is able to receive a viral load test, that the child is being monitored to be on prophylaxis and receives the DBS testing. You cannot expect every clinic to have it all at hand if you only identify 1 or 2 women, but when they are identified, we need to put something in motion. I think the country has done very well in other infectious diseases. If there is a cholera outbreak, we know through case-based surveillance on how to set up special services to contain the situation. Why can't we do that also for PMTCT? Because I think that is the way we have to go. The other area that I would like to highlight is the use of point-of-care technology. The country is still relying on a very centralized system for laboratory services, and we have rolled out gene expert machines for TB case identification and at a certain extent also for viral load testing, but the point of care for early infant diagnosis is hardly used. And I think if we, for example, want to learn from a country like Botswana, that is the first country that has reached the path to elimination, they have point-of-care services almost in every district, and we don't. So I think there is still some opportunities. And my last comment is, and also to appreciate and thank actually the Ministry of also taking us to the next step of elimination of mother-to-child transmission, because we have been focusing on HIV, but we are moving already ahead. We have also syphilis, which has been undervalued in country, and hepatitis B. And triple elimination is the new agenda for the WHO. And I'm also glad also to share with you that the Ministry of Health has just launched the EMTCT plan number 3, which includes also efforts to eliminate syphilis as well as hepatitis B. Thank you.
Thank you so much, Roland, for your very nice points with regard to HIV and mother-to-child transmission elimination. My last speaker, before we move to question and answer session, Dr. David Sando, how do you foresee HIV control efforts towards 95, 95, 95 in the light of COVID-19 pandemic? Your talking points should be based, what is 95, 95 mean first, and which one was affected due to COVID-19 pandemic? And any lesson learned, and if you do have any innovative strategies employed in that perspective. Karibu.
Asante. Thank you, Dr. Chilo. Thank you, my colleagues here. And yeah, so it's really glad to be here. I see there are so many experts actually working in HIV, and I'm sure that we're going to have a very good dialogue around these topics. Roland have covered maybe some of the answers, but so I'll try not to repeat that. But as we all know that COVID-19 pandemic, we had the first case in Tanzania. It was in March 2020, and since then there was escalation of efforts towards combating the spread and the impact of COVID-19. Including COVID vaccination, which started toward the end of last year. And all of that have come with a big toll in terms of HIV epidemic control. We have seen an increased trend, most of it anecdotal, but we've observed actually in terms of mortality and morbidity, number of hospitalizations have actually grown during the period of 2020 to 2022. And most of this is associated to COVID-19, but it also affects the environment under which HIV care and treatment support is being provided. So to a large extent, there have been overstretching of the existing healthcare system to the extent that a lot of effect have spilled over to the quality of HIV care and treatment services that are being offered in the country. In terms of PLHIV, people living with HIV, when you talk of the 95, 95, 95, so these are the three ambitious targets, global HIV targets, where the countries have committed themselves to being able to reach at least 95% of people who are living with HIV/AIDS, to test them and let them know of their HIV status, and then make sure that 95% of those who knows their HIV status are put on treatment, and of those who are put on treatment, at least 95% of them are being viral suppressed. And this is the target that superseded the 90-90-90, which was the 2020 targets, and the timeline for this is 2025. So ideally, our country have committed to achieving this 395 by 2025. But when you look actually at the impact of COVID-19, we know that during the pandemic, especially during the peak, there was disruptions in terms of the services.
the ART provisions. Most facilities struggled to contain cases that were suspected of COVID-19 to an extent that there was, a disruption of ART services in terms of the existing clients to be able to maintain their appointments, but also to reach out to new clients. So to a certain extent, the service provisions were disrupted. But again, also in our country, especially for our case, we needed to start acting immediate. And so part of the funding which was allocated to HIV care was now directed to support COVID pandemic. So to a certain extent, there was a reduction in terms of funding to HIV care and treatment supports. And all of these have an impact either in terms of the number that is reached, but also the quality of the processes that we are really implementing daily to make sure that there is timely and equitable services to HIV services. In terms of the general population, and this is important because when you talk of the 395, even though we wanted to reach the first, testing 95% of the people who are living with HIV/AIDS, the risk of HIV infections have gone up also during the COVID pandemic. We know that, for example, girls and, where there was school closing down. So we know a number of girls and, young people were out of schools for some time, including colleges, and being at home doing nothing, that predisposed. And we have now evidence from other countries where they have done research that the number of teenager pregnancies have gone up. The age at sexual debut has also gone up. And all this is actually due to the effect of COVID-19. Working from home has also to certainly exposed people to some of the risk behaviors, including in our community. I'm not sure if you've observed, but even alcoholism has gone up. Because people have now been, stranded at home, working at home, and for some reason that has promoted some of the behaviors that really increase risk of HIV. And to a certain extent, this is now being seen in terms of our trend on a reduction of HIV new infection. So when we say which of this is affected, in actual sense, all of the 395 have been affected. In terms of the number that was expected to be tested, so now the denominator has increased. The Ministry of Health, through National AIDS Control Program, had a target of reducing the number of new infections from 81,000 in 2018 to around 12,000 in 2023. And when the 12,000 is 2025. So in order for the country to be able to achieve 95 as the pathway towards epidemic control by 2030, we see that the denominator, which is the number of people living with HIV/AIDS, is more likely going up at a speed that is higher than the speed before COVID pandemic. In this case, for example, last year, the target by the National Multisectoral Strategic Framework for HIV was to reduce the HIV new infections by 75%. But when you look at actually what we've achieved is only 25%. And the target is so last year the target was to at least have new infection, around 110 new infection every day. But what we saw was around 140 new infection every day in the country was happening. And for us to actually be able to achieve the required level for epidemic control, by next year, the intention is to have at least 30, reduce this to at least 30 new infection every day. However, when you look at the number, it's more likely that will probably be around 100 or 110 new infection by next year. So really, in terms of sustaining the gain, to a certain extent, the gains have actually been reversed. The curve has kind of like flattened, and so we don't really now observe the steep slope in terms of, the speed towards achieving the epidemic control. And this has a toll. When you look at, Roland was talking about the, care coverage, it's pity to actually know that 1 out of 2 infants who are born of HIV-exposed infants, exposed mothers, they don't have access to early infant diagnosis. So about 50% of all the infants in the country, as we speak now, who are born from mothers who are HIV infected, do not get to be tested. And that's a big risk because it's adding a pull into our HIV population. But even when you look at the distribution of HIV, even though the HIV prevalence among adults is around 4.5, but when you look at the special groups, for example, female sex workers, you are talking about 15% of them. So 15 out of 100 female sex workers. When you talk of men who are having sex with men, you're talking of close to 9% of them having HIV infection. So we still have subgroups who the epidemic levels are still high, and if we are not really able to address these hotspots, it's really hard to see how we'll be able to actually achieve the epidemic control. Even the ART program, as Roland have said, there's a lot of inequalities in terms of how the services are being supported. And even when you look among the age group, actually, women, we've been very good in terms of reaching to women and enrolling, linking them to care. We have close to 93% of all the women who are required to be on ART, receiving ART. But when you go to men, you see that drops down to around 80%. So only 8 out of 10 men who knows their HIV status are now being, receiving care. And when you go to children, actually it goes further down. It's only 6 out of 10. So children, even those who have been tested, still it's only 60% of them who are receiving ART. So when you look at these numbers, you see that even the second 95, which is really retaining, putting them on ART, we are still not doing very well. And all of this could be part of the effect that COVID-19 have resulted in. So it's very important to make sure that we come up with innovative strategy. One thing that is very clear is that the strategies that have actually gotten us this far are not the same strategies that are going to take us to the last mile. So to close the gap, it requires different innovative strategies that would be actually client-centered. In many cases, we've been, as public health experts, sitting down, designing the type of care and delivery model. But to be able to reach the last mile, the few that we haven't been able really to engage them into care. These are clients with different characteristics, different patterns of health-seeking behaviors, and if we are not able to engage the community and redesign our type of care, it would be very hard to actually link them to care. And even in cases where we would be able, we might not be able to retain them. So these are skewed kind of a population that requires a different type of approach to be able to attract them and receive the care. So more efforts needs to go into coming up with more innovative, client-centered, and this also talks about the quality of care that we're actually offering. So we've been pushing more for enrolling, covering more, but the quality has been really poor. And I'm glad that my brother Isaac and before this session, they were talking about quality of care. Quality of care, we've started talking about quality of care, but we are still paying lip services. When you look at quality of care, we are more focused on the technical component, but quality of care also involves the interpersonal care, really the client satisfaction. How do we transform our care in a way that would ensure that the experience of clients when they come to our clinics will be, matching their expectations. So clients' voices, beneficiaries' voices needs to be integrated now as we redesign the type of care that we want to do. And also the allocative efficiency. It's also an important component of care. As we are now stretching into this last mile, the resources are definitely not going to be increased. We need to be very efficient in terms of how do we allocate our resources? How do we synergize and leverage the resources we have? So those are some of the lessons and that we've learned, and I think it will be important for us to think through as we address and try to achieve the last mile and close the gap to achieve epidemic control.
Thanks so much, the speaker. Please, a big round of applause. So it's an excellent, good panel, of experts here. So let us go straight to the Q. You have to add something? Kalipsa.
Yes.
Dr. Ali.
I just want to, before we start the session, I want, because we are now at the, last year, there was an announcement from WHO to recommend vaccines. So I want to inject some perspective to aid in the discussion, or at least stimulate the question from the audience. So I want to say that it has been a goal of the international community, especially malaria community, to come up with a vaccine. So the question was, what type of vaccine are we talking about? So the WHO put a roadmap, in 2013, saying that we need something which is 75% effective against clinical disease by year 2030, okay? So that was the goal. At the moment, we have RTSS, which is giving us a 30% efficacy, or to reduce the risk of getting severe malaria by about 30%, okay? And this is the vaccine that we are told to go on and use, okay? So I want to throw those numbers for the audience to ponder about and maybe ask questions around that. And the question is, what is on the horizon, okay? We do have sort of next generation vaccine, which currently, recent one, which was published, I think, a few months ago in a Lancet, and this was a small study. It's a phase 2 study which was conducted in West Africa, in Central Africa. And the efficacy there was 77%. And now this trial is sort of being undergoing phase 3 trials across 4 countries in Africa. Do we wait? Do we go with this? I'm throwing that to the audience to maybe ponder, then we can discuss this. And then I also want to throw something else. The need for the vaccine at the moment, when I was reading yesterday the WHO documents, we need about 100 million doses per year. Okay, these are the doses we need in Africa, in those countries that are in need. We cannot produce 100 million doses per year. Okay, so it comes down to prioritization. Who gets the first? So WHO came with a framework, which has, I think, about 5 criteria to select. Are these fair criteria? Are these the ones we should go for? Okay, and what will be the impact? Okay, and ultimately I want to say the cost becomes a very important issue. You asked about the challenge earlier. The cost is an issue. At the moment we are talking about a hypothetical number of about $5 per dose. This vaccine at the moment requires 4 doses. So this is what at least the evidence we had in the phase 3 trial, which I think took part in about 7 countries, including Tanzania. And the 3 doses we know doesn't give you that much, sort of impact. So you need the 4th dose, and this is the reason why there was this implementation program across 3 countries, Malawi, Ghana, and Kenya, to try to figure out the practicality of giving the 4 doses in a real setting, because the 4 doses, the evidence we have, was from a clinical trial, heavily funded, heavily controlled. But now we're talking about in real setting, can we give the 4 doses, given our current rates of, compliance to immunization, etc. So I think the 4 doses, it's very important to think about the cost. So the Gavi have signals they will actually support countries in need to deploy the vaccine. But the Gavi price sharing policy is being reviewed now. So depending on the cost of the vaccine, this could also come back and create a bit of a challenge for some countries to be able to get the vaccine and deploy it to the people who need. So I wanted to throw those numbers in there so that you can stimulate the thoughts and the question. Thank you.
Thanks so much for additional points to our audience. So please, without wasting more time, I would like to welcome the participants. Yes, Dr. Frederick Haraka.
Thank you, Dr. Chilo. Thank you also for introducing. My name is Frederick Haraka. I'm a medical doctor from ECBAF, and I would like to really start where Dr. Ali ended on malaria prevention. So Ali, I wanted to understand your thinking around the whole concept of vaccine. We know that Malawi is taking a step, and they have started a programmatic vaccination. You can correct me if I'm wrong. But also we do have ITNs for malaria prevention. And currently we do have a vaccine that is, the efficacy is somewhat suboptimal. Now, as an expert, what would you recommend for the country, particularly that should we go for a malaria vaccine rollout, or versus what we currently achieve in terms of the ITNs that are being used? Thank you.
Another comment or question? Yes, we have someone here. Introduce yourself, just name and then continue.
Asante sana, thank you. My name's Eric Shaw, working with Engender Health. Not sure whether this is a question or just a proposal. In our experience working with many facilities in Tanzania, we find so many investment made on the service provision, and we not too much put the effort on talking about the commodities. And looking at the expiring commodities at the facility, we find like HIV commodities, a lot of them expiring, and it is because of the notion that these commodities are free commodities. And the other program commodities like the malaria commodity, we're talking of the testing kits like RDTs. I'm thinking it's a high time now as we do the research on the increased infection or decreasing infection rates and putting all the measures of control, we think also making a very good ration of the commodities inside, and probably initiate the researches that involves commodities more. And I talk about this because I'm a pharmacist and it is an area of interest. Looking at all the presentation made across this summit, we find people talking of the infection rates, how many people are infected, how many researches were done, but no many researches done on the commodities availability and the supply chain. Asante sana.
Thanks so much. There's a hand there. There's a lady.
I'm Theodora Mbunda, working with MDH. So my question goes to Dr. David Sando. So in the line of a summit theme that we're talking about quality of care, and all of you have spoken a lot about infectious diseases and what has been done in the area of infectious diseases. But as a country, we have seen that there are a lot of efforts that have been put forward to address a burden of double burden of communicable infectious diseases and non-communicable infectious diseases. Now we are facing the epidemics of pandemic diseases, including, COVID and HIV itself. So what is your opinion on the country's preparedness to deal with both? And what should be done to sustain such efforts? Thank you.
Those a hand at the back, or is it? And then we come to the. What's your name and where you come from, and then ask the question.
Yes, I'm Florian Mtasingwa, working with MDH. Hello. Considering the case of vaccination, I have a question to Dr. Ali. We have experienced the challenge of aligning to clients who need second or third dose so as them to have a full vaccination. Now, as you can see, the malaria vaccine needs at least 3 or 4 doses for an individual to have a full vaccination. Now, have we thought of the risk of defaulters, considering that about 1 dose costs about 5, and previously we know that while implementing the COVID-19 vaccine, was the preference, as most of the individuals who got just a single shot had a full vaccination, and as programs, we had literal hurdles in struggling to make sure all clients who have at least 1 vaccine come back for second vaccine with those vaccines. Can we what is the plan towards handling the defaulters or the risks of defaulters who have at least 2 doses or 3 doses, but also need more investment to track those who need or more doses for them to complete the full vaccination? Thank you.
My name is Dr. Faisal Hood. I come from Aga Khan. My question goes to Dr. Sando. To achieve the 95, 95, 95, do you think an opt-out policy for all patients who are treated at our health facilities, meaning that by default, all patients who come to health facilities will be tested for HIV unless they want to opt out, would that increase your goal? And do you think that will be implementable by policy?
Question, Dr. Mary Rose, and then we will allow time for the speakers to respond.
Thank you very much, moderator, and I really wanted also to congratulate all the speakers. And my question goes to Dr. Sando. I'm very much interested with many engagement to HIV care. And based on the evidence, including your own verbal evidence, that 8 out of 10 men, they are currently linked to care. So I really wanted to know, based on your experience and also MDH rich experience, what innovative strategies do you have to make sure men are really championing when HIV care and linkage is concerned?
Question, Dr. Isa.
Thank you, moderator. And again, also let me share my, also join my colleagues to congratulate the presenters. You've done a very wonderful job, very rich information. And I think many people are pondering what you've, the information that you've provided. So I have one for Ali. I just want to understand, I think what you've said is the last one, the last comment regarding whether we have to choose whether we should go for the vaccine or not. I think most of or us, the public health specialists, we are very excited when we heard about the news of the new vaccine. We're thinking about the mortality rates, the under 5 mortality rates in our country, heavily contributed by malaria. We even see there was an increase of neonatal mortality due to malaria in some recent years. And so maybe we need to think, you know, you say the efficacy, you say the efficacy was 77% after the fourth dose or after the third? Was it after the third? Okay. I think I would say if you compare the cost of treating malaria and the cost of even follow up and identifying a kid who has malaria, treating them, testing the malaria test itself, and the cost of those vaccine, we need to, maybe people need to do some sort of analysis and advise the countries, because I think my colleague, somebody said that Malawi is already starting a program, and I think for Tanzania, we should really push for this. We are usually dilly-dallying a lot, so much when these kind of new, I would say, scientific evidence come out, and people starting finding like a negative part of it instead of thinking the positive and how it's going to save lives of many, many children, especially now when we're talking about universal health coverage and leaving no one behind. So maybe people here will also think of how to consider this. But I think if the cost is cheaper than to treat, and we better just maybe think of how we should advise policymakers. And another one is for Dr. Sando. Thank you so much for your presentation. And I was interested when you talk about the remaining, the gap that we are closing now is extremely difficult, and it's need a very, I would say, very innovative strategies, as you've said. And people are talking about hotspots, they're learning, know your demography, know your population, know your clients, etc., etc. But how you'll penetrate the communities and these difficult communities which are now we are trying to find. So is there any best practice that you can even share or experience from MDH program, which I know covers as a large coverage around the country, of what maybe strategies that you feel that have worked and that people should consider, and what are the kind of challenges that you foresee in terms of closing this gap? Thank you, moderator.
Also, excellent questions and excellent comment. Please let us allow time. I think, Dr. Ali, you have a lot of questions. Maybe you should start.
Okay, thank you very much. Yes, so I would start with the first question from Dr. Haraka there. I think, so Haraka asked about the current tools vis-a-vis the vaccine. And I want to just also maybe clarify that I don't know about Malawi now, but after the phase 3 study, which was conducted in 7 countries, that I said, for the RTSS, then of course there were some there were some programmatic questions that had to be addressed. And there were also some safety issues that also were to be addressed. And one of the programmatic question was, the practicability of the 4th dose in the community. So part of the implementation program that was, supported by WHO was exactly to address some of these challenges. So one, to see whether this can be done in a real setting, and that involved, of course, Malawi, Kenya, and Ghana. So these were the 3 countries where I know over, I think, 800,000 kids were involved, and it was done in a programmatic way. So it was actually part of sort of trying to address that question. And part of it was to look at the issue of safety, which was also very important, because there's some safety signals seen in phase 3 study, which were sort of concern. And therefore it was important to do it in a larger sort of pilot program to be able to really verify if they were really safety signals or not. Glad to say, of course, they didn't they didn't confirm any of those safety signals. There was an issue with the increased, frequency of meningitis in kids who will be vaccinated. They didn't see that. There was imbalance sort of seen in mortality in female versus male in phase 3. They didn't see that. That is a good thing. And I think the highlight outcome was this 30% impact, at least after the 3 doses,
on severe malaria, cases of severe malaria. And no, of course, the mortality, the under 5 mortality, the contribution to the under 5 mortality is high. So if you have severe malaria, probably you're going to have more death. Of course, the implementation program, as far as I know, at this point, there haven't been any updates in terms of the actual impact on mortality and also actual evidence on the impact of the 4th dose under the real settings. Of course, we saw that in a phase 3 study. So the 30% I want to emphasize, to clarify, this well and above other interventions, so including the ITNs and other. So I think there's an advantage there of using a vaccine because the 30% has taken into account the use of the ITNs. So obviously, if you wanted to choose, you would definitely go with that. So I wanted to also bring an issue of the numbers we're talking here. Again, malaria, which, malaria causes a lot of death, especially in under 5s. And it's the same story, I would say, I would try to remind people of the rotavirus. When the rotavirus was being rolled on, the efficacy was not 90%, was not 100%. It was around 30, 40, 50%. But we looked at the impact. And this actually translated into a lot of life saves, especially young children. So I think I wanted to sort of also clarify that when we are thinking of introducing the vaccine, we should also think about the number of cases, number of deaths that will be averted with even that modest efficacy. But what I was trying to say is that we shouldn't, again, I'm speaking as a researcher now, we shouldn't end there. I think there's still a lot which needs to be done. And with sort of upcoming candidate vaccine, this is something we should always be considering to deploy once it is available, for instance, because definitely it will add on. I want to say, for a malaria community, this is a significant milestone, and we should not really water down this kind of an achievement. It is an important achievement, and it's better to have something rather than nothing. So adding this on top of our other tools we have, it will be something very helpful. So just maybe to link back to the last question, I think you were spot on to say that we should look at how to deploy it and where to deploy it cost effectively. And I think WHO here is also helping. Of course, bringing experts from across Africa to think about this. I talked about the lack of sufficient doses to address, to cover the needs. And I think the framework, which talks about prioritization, has about 4 components. So number 1 is, of course, the need. So going to places where really there's a need. And how do you define it? Of course, one criteria which has been suggested is to look at the malaria prevalence, but also to look at the under 5 mortality. So if you have a highest sort of a composite score that sort of combines high prevalence and high mortality, these are the places to go, okay? And then number 2 is actually the impact. And someone talked about the EPI vaccination and defaulters and, and compliance. This is very important, but as I said, 4 doses are the most important, would have the highest impact. And unfortunately, it is actually countries with the highest sort of need which are more likely to have some challenges, infrastructural challenges, to actually ensure that we have all the 4 doses to have an impact. So I think this is very important for countries, programs to think about, and also for other stakeholders to think about and support these countries. Because otherwise, it will be like, throwing the vaccine there and you don't have a sort of an intended impact. And the number 3 is, of course, equality, reaching those marginalized populations and the vulnerable population. And then the 4, of course, is equal sharing. So I think these are the priorities that to be looked at. And I think these are the very important suggestions and recommendation that countries should, that the international community should use in identifying who needs to get the vaccine first. So I would say definitely it's better to have something rather than have nothing, and save children's lives. The other, so I think I've addressed the question on malaria for now. So if I miss something, maybe we'll discuss it further. Over back to you, Chair.
Dr. Sando, please.
Yeah, thank you. I have questions here that I think I would just share my views, but I hope there are so many other experts that maybe would be happy to share their experience from different institutions, but also I know time might be a limit, so hopefully after this we can continue with the dialogue. So the first question was on the quality of care and the double burden of disease that now we have NCD and HIV. With the gain that countries have achieved or rather realized through the ART program, one of the major milestone is longevity of life among PLHIV. So now we can, for sure say that PLHIV can attain, or their life expectancy curve is more, it's kind of aligning now with the normal life expectancy. So with that comes challenges, because most of our countries now, over time, our life expectancy have also improved. To a certain extent, it now provides a room for chronic diseases to really grow and mature and show up. So now we are seeing surfacing out of symptoms and diseases that are NCDs at a large amount among PLHIV. And we are able now to keep them in care with ART, protect them with infectious disease, but the NCDs are now killing them. And I think that is the challenge we are seeing now, that the like of hypertension, diabetes, hypercholesteremia, they're all coming up, and these are now major causes of death among our PLHIV. What should we do? I think the first thing is the quality of care. We've talked about quality of care. It's sad that most of the time we talk of quality of care and it looks like we have no idea what is quality of care. We talk of quality of care, but sometimes we confuse performance, coverage and quality of care. So quality is a different notion. It's not something that you measure using the metrics that we are actually measuring now. So even though we are talking of quality of care, no one can for sure say where are we in terms of quality of care. Unfortunately, most funding mechanisms are not interested in quality, but rather the quantity. So most of the indicators that we have in our systems at a national level within the IPs are focusing on the quantity. How many we've tested, how many we've put on ART, how many we've retained, and those are not quality. Quality, it has to do with the experience when the contact at the facility is made. What really happened during the contact in terms of the processes. If it is counseling, what was the content and the quality of the counseling? If it is, index, tracing. So it's not really about how many have you tested as index, it's the quality of that process, because through that process there are a lot of pathways towards, minimizing risk of HIV transmission. So I believe that we need dialogues at a national level and also subnational levels on what does quality mean in our context. We should come up with very objective definitions of quality as far as HIV care is concerned, and then come up with metrics that we should deliberately integrate them with our routine, reporting mechanisms. Right now we have, I think at the NACP there is a quality guidelines that is probably outdated, but when you look at even the metrics within the quality, majority of them are not really quality indices. So I think there's a need to really to capacitate ourselves to really understand what does quality means and how can we integrate quality. The second thing is, and this really needs revolutionizing, our thinking, really thinking out of the box and not business as usual. Since NCD is coming up, we can't be, ignoring that among our clients. So what we are seeing, And I'm glad that PEFA has, I've engaged in some consultative meetings with PEFA. We're now slowly starting, they've now accepted, and slowly we'll start seeing some, flexibility to be able to use some of the PEFA fund to address the NCDs within the PLHIV. But that is not enough. We really need to do more than that. So we can't be testing and referring these clients to go somewhere else. We know that HIV is a chronic care and NCD is also chronic care. We can't afford to have people who have 3 or 4 appointments in a month in a facility. You come to HIV clinic, you have another appointment for hypertension, another appointment for diabetes mellitus. Will be that for retention purpose, that will not work. So we are more likely to lose these people, and for that matter, we need to be bold and make a decision. As a country, should we revolutionize our care and treatment clinics, CTC, into chronic care clinics, where HIV, TB, HIV, hypertension, diabetes are all being, managed within the CTC, so that CTC is not only for HIV, any chronic care, so that we have under one roof all the services. That requires, bold decision, but I think as a baby step, it's a good step to start introducing NCD care into PLHIV. But as we build that capacity, we should start thinking on a chronic care model where our care and treatment clinics, which are very, furnished, nicely funded, well-funded, can also start to think on, providing care for NCD. And this is important because now we've moved to some of the differentiated care models like multi-month drug, appointment, where the congestion within the clinics are going down because clients are given 6-month, appointment. With that case, it means if a clinic has, let's say, 500 clients of HIV, with 6 months, it means these people are only making 2 visits in a year. The clinics are becoming empty, and that provide a room and a space to also add on, other chronic diseases. So I think those are important in terms of, maintaining the gain, but also addressing the challenge that we are seeing of NCDs. Because of the time, maybe I'll be brief like that. So the other one was the opt-out policy. So the opt-out policy, I think this is the policy we are now implementing. For now, if you are a pregnant woman, you go to the clinic, you're not really requested to consult for HIV. You are being told that you'll be tested. So unless you opt out, you will receive that service. However, we know that during the discussion, and I think most of you have experienced, our epidemic have moved. It's no longer, concentrated within the general population. It's concentrated in specific subgroups within the population. What does it mean? It means if I go now to Muimbili and decide to test everyone who is coming there, I'll probably test 10,000 to get 10 people. Because it's not necessarily that, the general population is highly affected. We have subgroups, so we need to have a more targeted, HIV testing and identification mechanism. And for that matter, now we have subgroups. And the problem is where the HIV is concentrated more, they're the people who are less likely to come to the clinics. The good thing is our ANC are doing so well, so women are coming when they're pregnant. We're able to identify and put them in care. No wonder we have more women identified in care. But men are less likely to come to the clinic unless they're really sick. You talk of adolescents. You talk of, minors, those in mining. So we need to come with more innovative strategies to really reach to them. And I would actually connect this to the question about the men. And this is where the newly intervention like HIV self-testing, men likes this. You find a place, you say, hey, you can take a test kit and go and test yourself at home and give us a result. So these are one of the, innovative strategies that might be very helpful. In Dar es Salaam, for example, we also have the condom vending machines, which I think they are also somewhere else. Yes, the condom vending machines, now we are able to actually provide condoms through a vending machine. So you might go to, let's say, Sinza, in places where there's hotspots at the middle of the night. All the stores are closed. You can go to a vending machine and then get your condoms. So the thinking is, can we expand that service to include, let's say, PrEP, to include ART in a long run, so that, you don't have to have a fixed time to go to the clinic if you're stable, you can just go to this place, get your prep, and then you're done. We can take some, whatever information about you there. So the good thing is we can put codes and you can go there and you can fill in some questionnaire as you are taking the prep before it dispenses the prep, and then we have your information, all that we needed for refill. So those are some of the innovations that I would probably, I know that the time, I'm told the time is out, but I think there are quite a number of strategies, but more needs to be done in terms of engaging men, engaging adolescents and young women on how we should really revolutionarily reform our care delivery models to the model that best suit them, so that we are able to reach and close this last mile. Otherwise, we'll only be able to retain those who have retained now, but those who have not been retained are not retained or are not linked to care, because they definitely display a different characteristic and preference to care than what we've been able to implement so far. Thank you.
Thank you so much, Dr. Sando. Please, Roland, do you have a response for the questions, please?
Thank you. And I think Dr. Sando has really responded to many of them. I think there is one comment that has not been highlighted, and it's maybe one that is also a little bit outside the box, is the question of Eric about the commodities research, because I think we always look at service delivery models, and one of the challenges the service delivery models have is the availability of commodities. And so it is actually a good point. It was not really a question, but more of a concern. Can we also look at how can we be more efficient with our commodity distribution, avoid not only stockouts, but as he rightly pointed, we also have clinics that have expired drugs, because there has been a push for a lot of drugs and then they are not being utilized. So I just want to highlight, for example, in one area in the EMTCT program, the prevention of mother-to-child transmission, is the availability of DBS test kits. To have those exposed infants tested is a huge challenge in the country, and I just highlighted that we have over 4,000 dispensaries that only see 1 or 2 positive women per quarter. How do you make sure, because you cannot just stock drugs in those clinics for the 1 or 2 that are coming, and you have ARVs there, you have DBS test kits there, that's when they expire. So we need to think of innovative ways on how can we set up a drug delivery system that is more targeted and more client-centered, that when we identify 1 positive woman in a quarter in a dispensary, how do we set up drug delivery systems rather than telling the client to say, now you go to another clinic because that's where you can get your ARVs, or that's where your child gets tested. And that's why we are losing those women and children in those small dispensaries. So it's a good question, and I think it is also something that we all should take up on how can we come up with more efficient commodity delivery systems. So thank you for that comment.
Thank you so much, the speakers. I have just one question to Dr. Ali. When should we expect the vaccine to arrive in Tanzania? I mean, when should we expect the vaccine to arrive in Tanzania, malaria vaccine, based on your experience?
Okay, so I think that's a very tough one. As a country, of course, we have processes when it comes to new interventions. And likewise for this vaccine, I'm glad that the Ministry of Health has in collaboration with the National Malaria Control Program, have started, I'm sure, a couple of months actually before the WHO recommendation to look into this. And I know the NITAG was tasked to look at the data and to advise the government sort of the way forward. And the NITAG, of course, reached out to some of us, to researchers who worked on this vaccine, and we have provided our insights and our recommendations. So I think one of the challenge to address that question is the process which I've just described. Because of the scarcity, it is going to take a while, because now we have a framework, and then countries have to come up and apply, okay? And through Gavi, for countries who are, can apply through Gavis, and those countries who cannot apply through Gavi, they have to go through WHO or UNICEF. So I think it is now upon countries to sort of get their act together and move forward and apply. We will not be able to get probably the numbers of doses we think we need, perhaps because of the scarcity. So it's going to be sort of distributed. So how many doses will we end up with? I don't know. But how are we going to distribute that? Which are the areas which need to be identified? I mean, it's so complex. I'm kind of hesitant to say the date, but I think there's so many things which we need to look into as a country. We have a stratification model looking at different sort of risk of malaria. Probably need to use that to identify areas, get the numbers, and then move forward and make that application to Gavi. But I think that would take a lot of in-country discussion within the country with all the stakeholders. So I'm sorry, I don't have the date.
I understand. Because we are recording, so we can quote you once you give us the wrong dates. Thank you so much. A big round of applause to our speakers, please. So if you need any more discussion there, I think they'll be around for a couple of hours. We have tea time now. A few announcements. We have just confirmed the Deputy Minister, P.O. Raj, Dr. Festo Lugange, will be here closing the sessions. And before that, P.O. Raj will host its session. It was supposed to be before this session, but now we shifted to Mikumi from 4 p.m. to 5:30 p.m. And this session will be also attended by Dr. Festo, and then afterwards, he will go to close our Tanzania Summit this evening. So it's time for tea, so please welcome to the tea.
Before we move, the next session will start from 10:30, and we'll be having the two forums for research for development and Pathfinder. Research for development, FHM Engage, will be in this room, and Pathfinder will be at Mikumi. Karibuni.